Duration. ஆமா கூப்பிட்டுங்க யாராவது வர சொல்லுங்க கூப்பிட்டுங்க ஏன்னா அந்த வெபினார் ஆரம்பிச்சுட்டு வந்தேன். You guys able to hear me?
Yes, sir.
Yes, sir.
Yeah, okay. I'm sorry, I think I have a problem with my video. So, good morning to all my students, 2017 batch, fellow classers. Good morning, everybody. Really proud moment for all presenting. Can I audio disturbance? Can you put off your audios, please? Only the presenter has to be unmute, mute. Yeah. First presenter is it Anaga or who's the first presenter?
Sir, I am Sir Hariharan. Sir.
Hari. Okay, good. Hari. Okay. Sorry, Hari needs no introduction. I think he's really well versed in all these kind of things. So, Hari, all the very best. Do your best. I think you've been given a very nice topic. So go ahead with your presentation. I'm listening. I'm sorry about my video. You guys should carry on. Yeah, start your presentation now.
Okay, sir. Thank you, sir.
Yeah, all the best.
With immense pleasure, we welcome you all to the webinar 20, Neuro-Ophthalmology, a part of oculofest 20. Respected Honorable HOD Sir, Dr. Parthiban Sir, Head of the Department of Ophthalmology of KPV Government Medical College and Mahatma Gandhi Government Hospital. Vision is the art of seeing what is invisible to others. Our HOD Sir's vision instills us a feeling of curiosity and inquisitiveness in the field of neuro-ophthalmology. This webinar 20 is a part of the extremely successful virtual extravaganza, oculofest 20. I, along with other 4 of my batchmates, are gonna present on various topics. Each one of us will deal with a topic, and at the very end of the session, we will be providing you with 2 to 3 questions which are MCQ based, which all of you can answer. And this will be an interactive session. Please be attentive throughout it. Now, first, let us get into visual pathway. The understanding of visual pathway is imperative for us to appreciate the fascinating and enigmatic subject of neuro-ophthalmology. Let us go straight into contents. Introduction. Optic nerve, parts of the optic nerve, lesions of the visual pathway, field effects, and the summary. Introduction. The visual pathway starts from the retina and consists of the optic nerve, the optic chiasma, the optic tract, lateral geniculate body, optic radiations, and the visual cortex. The visual nerve pathway. As you can see in the diagram here, we have an apple which is being visualized by the eye, and inverted image appears on the retina via the optic nerve, reaches the lateral geniculate body, and then reaches the occipital lobe. In this picture, you are able to see the various fields, visual fields, and how they are being transmitted by the various optic nerve, optic chiasma, optic tract, and other components of the visual pathway. First, let us go for the optic nerve. The optic nerve starts from the optic disc and reaches till the optic chiasma, where the 2 nerves meet and the nasal fibers undergo decussation. The optic nerve. Optic nerve is morphologically and embryologically comparable to a sensory tract. It is not covered by a neurilemma, but the optic nerve fibers are very fine. Let us compare a somatic sensation with the visual sensation. How we have a somatic sensation of the nerve endings in the skin, then the posterior root ganglion, then the nucleus gracilis or cuneatus, and then the thalamus. Visual sensations are by the first order neurons of the bipolar cell layer of the retina, where rods and cones act as a sensory end organ which take up the stimuli as a receptor. From there, you're getting into the ganglion cells of the retina, which are the second order neurons, third order neurons from the lateral geniculate body. Parts of the optic nerve. We have four major parts: intraocular, intraorbital, intracanalicular, intracranial. Intraocular is 1 millimeters, intraorbital is 30 millimeters or 3 centimeters, the longest part. Intracanalicular 6 to 9, intracranial 10, which is inside the cranium. First, let us go for the intraocular part. Intraocular part pierces the optic disc. That is, the optic disc pierces the retina, the choroid, sclera, and from the sclera and choroid, this piercing causes the optic nerve to be produced. And then you're having the lamina cribrosa structure, which is a sieve-like. Then we are going for the intraorbital part. Intraorbital part of the nerve is present within the orbit, posteriorly related to the annulus of Zinn, anteriorly separated from the ocular muscles by the orbital pad of fat. Intracranial part. Intracranial is within the intracanalicular part, sorry. Intracanalicular part is closely related to the ophthalmic artery. And as you can see in the diagram here, it is inferolateral to it and the ophthalmic artery crosses over it. Intracranial, the one which is inside the cranium, closely related to the cavernous sinus. Here you are able to see the cavernous sinus along with the other nerve structures. The optic nerve is situated above superiorly. Finally, the optic chiasma. Optic chiasma is a flattened structure where you are able to see the optic chiasma in relation to the cellular tertica. Now, here you are able to see the nasal fiber decussation in the optic chiasma. The meningeal sheaths. The pia mater, arachnoid mater, and dura mater cover the optic nerve, as is continuous with other CNS structures. Here you are able to see the arachnoid, dura mater, and the subarachnoid space. Now the optic tracts. Optic tracts are the posterior continuation of the optic chiasma. Each of these optic tracts consists of the temporal half of the retina of the same ipsilateral side, contralateral side nasal fibers. Lateral geniculate body. Lateral geniculate body consists of 6 layers of the neurons, the gray matter neuron and the white matter, where you are able to see the first, second, third, and the remaining layers of the lateral geniculate nucleus. Optic radiations. Optic radiations are the nerves which are the connections between the lateral geniculate nuclei and the occipital pole, where we are having the dorsal bundle, central bundle, and the Meyer's loop. Here you are able to see the optic radiation, which is somewhat superior located, Meyer's loop, which is inferior. Meyer's loop is the inferior temporal radiations. Visual cortex. Visual cortex is the site of visualization, wherein we have the striate area, area 17, and other pre-striate and peristriate and parastriate areas of 18 and 19. Blood supply of the visual pathway. The blood supply is usually by the pial network of vessels, usually by the central retinal artery and the posterior ciliary artery. Now we can see the surface layer of the optic disc, which is supplied by the retinal arterioles, and the prelaminar region, which is by the peripapillary choroid. Here in the next image, here you are able to see the ophthalmic artery supplying it and the circle of Zinn. So this is the artery supplying the optic nerve, optic disc, visualized in this image. Fibers of the optic nerve. On cross section of the optic nerve, fibers are arranged in a particular fashion, which we are going to see in this particular slide. All of the fibers, if they enter peripherally, remain in the periphery. Those which enter in the center remain at the center in the optic nerve, but Macular fibers behave differently. As you can see here, this is the cross section of the distal optic nerve, where the macular fibers start from the periphery, and you're having the upper temporal, upper nasal, and lower temporal fibers in this particular fiber on cross section, which in the proximal optic nerve, the macular fibers get to the center of the optic nerve. In the optic tract, macula is above, the upper and lower peripheral fibers are situated below, and in the lateral genital body, it's somewhat similar. Now, fibers of the optic nerve, this particular image is represented taken from Parson, where you can see the same thing, macula at the side, macula coming in the center. Now, let us go for the actual clinically relevant topic, which is lesions of the visual pathway. There are many types of lesions. You could have the optic nerve, optic tract, optic chiasma, optic radiation, occipital lobe, lateral geniculate body. Lesion could be in any part of the visual pathway. Optic nerve lesions are our first topic, wherein we could divide it into the distal and the proximal part of the optic nerve. Here you could see a lesion in the optic nerve which causes monocular blindness, wherein one side of the eye, wherein this is the right optic nerve, so the right side of the eye, there is a monocular blindness. Now coming to the lesions of the distal optic nerve, salient features, there is a marked loss of vision, there is abolition of direct light reflex, but the near reflex is present. Common causes could be optic atrophy, which is described here, optic neuritis, which is represented in this image. Other than that, it could be ischemic optic nerve neuropathy, trauma, or anything other than that. Lesions of the proximal optic nerve. 1 second. Yeah. So the salient features include ipsilateral blindness. Then we have contralateral hemianopia. The ipsilateral monocular blindness is shown in this particular image, wherein the right side of the eye, there is complete lack of vision. Chiasmal lesions could be it's the next topic. Chiasmal lesions could be of intrinsic or extrinsic cause. Intrinsic means the chiasma in itself undergoes thickening. So this thickening could be due to a glioma, multiple sclerosis. Extrinsic causes are those wherein there is an external compression of the optic chiasma, which could be pituitary adenoma. Pituitary adenoma is the most common cause. You can see that particular pituitary adenoma compressing the optic chiasma here. So we are able to see it progressing anteriorly and compressing, because of which we are having a bilateral superior temporal defect shown in the diagram. Other causes could be trauma, metabolic, and other things. Images of various visual field defects have been depicted here. The chiasmal lesions of junctional scotoma, bitemporal defect, incongruous homonymous hemianopia. Now let us see each one in detail. Anterior, middle, posterior are the three types of the chiasmal syndrome. Chiasmal syndrome is a bunch of signs and symptoms which are seen together in a patient, wherein there is a lesion of the optic chiasma. Other than that, we have the lateral chiasmal lesions and retrochiasmal lesions as well. We could see the relations of the optic chiasma wherein the diaphragm muscle is below, and other things which you can see, as in the third ventricle is behind. First, let us go for the anterior chiasmal syndrome. Anterior chiasmal syndrome is due to a lesion in the ipsilateral optic nerve fibers, wherein the Willebrand knee could be affected. What is the Willebrand knee? Willebrand knee is the nasal fiber, the infranasal fibers from the contralateral eye. That is, if this is the right side of the eye, it is entering the left optic nerve just so to about 4 millimeters or so, and then again enters the optic tract of the contralateral side. If a meningioma affects this particular part in the anterior part of the optic chiasma, it could lead to a field defect known as junctional scotoma. So what is junctional scotoma? Junctional scotoma is a combination of both a central scotoma and a temporal hemianopic defect on the other side, that is the contralateral eye. So these together are known as the junctional scotoma. Middle chiasmal syndrome. Middle chiasmal syndrome is usually a syndrome affecting at the very middle of the optic chiasma, wherein both the nasal fibers deficit, usually because of a pituitary adenoma, which is the most common cause, leading to bitemporal hemianopia, where the temporal fields of both the eyes on either side are having a visual field defect. As you can see in the diagram, left temporal field and right temporal field, both of them have been affected. Posterior chiasmal syndrome. Posterior chiasmal syndrome is a syndrome wherein the posterior part of the optic chiasma is affected. This could even lead to optic tract involvement. In this diagram, you could see a craniopharyngioma affecting the posterior fibers of the optic chiasma. Usually, the posterior fibers are more sensitive. So, the most sensitive fibers could be the macular fibers and leading to a field defect in them. You could see an inferior temporal quadrant defect here represented in the diagram for the lesion here due to a craniopharyngioma. Now, the lateral chiasmal syndrome, laterally on either side of the optic chiasma, there could be a lesion. This lesion could be most commonly due to an aneurysm, atheroma of the carotid or the posterior communicating arteries. Because of this lateral compression, you are having a field defects affecting the fibers of both the lateral sides, which are nothing but the temporal fibers. So the temporal fibers are affected, leading to a bilateral nasal hemianopia, as the nasal fields on both the eyes are affected. Retrochiasmal lesions. Behind the chiasma, we are having the optic tract, lateral genital body, the optic occipital lobe, and other stuff. So here we have the right homonymous hemianopia, which is a field defect due to the optic tract lesions and optic radiation lesions, which lead to the superior right quadrantanopia, which is otherwise known as pie in the sky lesion. And macular sparing and bilateral visual cortex lesions can also occur. Each of these topics will be discussed in detail in the succeeding slides. But homonymous hemianopia, simply put, is a visual field defect on both the eyes in the right side, that is the right temporal and right nasal. Lesions of optic tract. Optic tract lesions could also be due to intrinsic and extrinsic causes. Intrinsic is due to demyelinating diseases, which is multiple sclerosis. Multiple sclerosis has been depicted in the figure shown, and you are having extrinsic causes, which most commonly is again pituitary adenoma, which compresses it. Pituitary adenoma compressing has been shown in this diagram here, which is a CT image. The characteristic features of the lesions of the optic tract involve the same incongruous homonymous hemianopia. Here, for example, if the left optic tract is involved, both the temporal and nasal fibers of the contralateral side and temporal fibers of the ipsilateral side are affected, leading to a right homonymous hemianopia depicted in the diagram here. Then there is something known as contralateral hemianopic pupillary responses or Wernicke's reaction, which is nothing but when we drop a narrow pencil of light with a torch, for example, on the non-seeing part of the eye, like in this part, the affected contralateral side of the nasal fibers or the ipsilateral part of the temporal fibers, then pupil will not constrict. But on the seeing side or the side wherein the fibers are intact, pupil will constrict. This is what is Wernicke's reaction. Next, lesions of lateral geniculate nucleus. We know that the cross section of the lateral geniculate nucleus, the fibers are macula fibers at above at the apex, the upper and lower peripheral fibers below. If there is a lesion involving only the upper and lower peripheral fibers, it will lead to a sectoranopia like this, wherein there is a gap in the middle, wherein the patient will be able to see. If at all only the macula is involved, it could be something like this. So a lateral geniculate nucleus could involve a homonymous hemianopia, which is incongruous. Incongruous as in not symmetrical. Lesions of the optic radiation. Optic radiations, we know that we have the Mayer's loop, which is the inferior temporal fibers, and we have other fibers in the optic radiation. If there is a lesion in any one of those radiating fibers from the lateral geniculate nucleus to the calcarine fissure in the occipital lobe, there could be visual field defects. As shown, a superior quadrantonopia, pie on the sky, pie on the floor, or a contralateral homonymous hemianopia with macular sparing. This could be due to a trauma, tumor, lobectomy, or any other cause. First, let us go to the characteristic features. The characteristic feature is the pie in the sky and pie on the floor lesion. A pie in the sky will be because of inferior most fibers of the optic radiation being affected, which are the Mayer's loop. So inferior fibers in the temporal lobe, which are the Mayer's loop, which is the inferior most of them. If there is a lesion, there will be a superior quadrantonopia. Inferior quadrantonopia, pie on the floor type of lesion is the superior fibers. The opposite, superior fibers in parietal. This can be visualized in this diagram again, wherein you have inferior, superior, pie on the floor, pie on the sky. This is another diagram representing each of the optic radiation lesions and others also, wherein you have the Mayer's loop defect here and the inferior quadrantonopia, superior quadrantonopia, and the occipital lobe lesion. So in case of a complete homonymous hemianopia, the field defect could be the entire optic radiation. If the whole of the optic radiation as shown in this particular part of the diagram is involved, it will lead to a homonymous hemianopia of that particular site. Okay. Now, lesions of visual cortex. Visual cortex lesions could be a visual field defect or other manifestations. First, let us go for the visual field defects. Visual field defects most commonly is a congruous homonymous hemianopia. Congruous homonymous hemianopia with macular sparing. This is the congruous homonymous hemianopia field defect, wherein you are able to see a sparing of the macula. Usually, macular sparing could be explained by a collateral vascular supply of both middle cerebral artery and a posterior cerebral artery supplying that region, which encodes for it. But if the macular field defect is following a head injury or gunshot injury, it affects right at the very tip of the occipital lobe, and this could lead to macular defects. As you can see in the diagram, we have the posterior cerebral artery supplying the occipital lobe and other features, middle cerebral artery too. But if there is the occipital lobe tip involving in any of the lesions, it will lead to macular field defects. Oh my God. Yes. So you are able to see a gunshot here and head injury in this particular part of the GIF. Visual field defects in occipital lobe lesions. You are able to see bilateral homonymous hemianopia with macular sparing, and we know why macular sparing has occurred. And this is macular defects shown. Other manifestations of occipital lobe lesions. There could be cortical blindness. There is a lesion in the occipital lobe leading to loss of vision in both the eyes. That is cortical blindness. Or else it could be dyschromatopsia or acquired colored blindness. The acquired colored blindness can be checked with the help of the Ishihara chart, which we have been represented here. Then visual hallucinations can also occur as represented in the image in this. Other manifestations. We have palinopsia, wherein there is a persistence of the visual image. wherein you are able to see a hand movement. Whenever a person moves a hand, the trail of the hand movements is visualized by the person. Visual anesthesia is transpositioning of one visual stimuli from one hemifield to the other, like from the nasal field to the temporal field. Polyopsia is when multiple images are seen as shown in the GIF below. A hand, we are able to see 2-3 hands, kind of. So to summarize, the visual field effects, we have the central scotoma when there is the retinal detachment, retinal injury. The optic nerve injury of the ipsilateral side could produce a monocular vision loss. Then the optic chiasmal lesions could cause a bitemporal hemianopia. If there is the optic tract lesions, a homonymous hemianopia. In radiations, we have the superior quadrantanopia and inferior quadrantanopia, depending upon the inferior fibers and the superior fibers being affected. There is macular sparing when there is the when there is the lesion in the posterior cerebral artery or at the very tip of the occipital lobe. Hope I was able to do justice in this vast topic. I thank you for your patient listening. I once again would like to take this opportunity to thank our respected HOD for giving us this wonderful opportunity. Thank you, everyone. Have a nice day. Now, we are going for a questionnaire session wherein you will be asked 3 questions, each question taking about 10 seconds each. So now I am going to launch a poll. You will get 4 options. Please choose the correct option for that answer. You can answer now. Thank you for answering. So pie in the sky type of lesion is mostly due to inferior fibers involved in the temporal lobe lesions. The next one, next question. Congruous homonymous hemianopia is a feature of occlusion of which artery? Thank you for answering. It is mostly due to a posterior cerebral artery occlusion. The final question of the session. Which among the following is the first order neuron in the visual pathway? Whether it's the rods and cones, bipolar cell layer of retina, ganglion cell layer of retina, or the lateral genicular nucleus. Thank you. The answer is bipolar cell layer of the retina. Thank you for taking part in this interactive session. Thank you.
Congrats, Hari. That is an excellent presentation.
Thank you, sir. Thank you very much, sir.
Really beautiful presentation. Kudos to you. I think the very concept of having a symposium for the students is to just able to feel how it is to be on the other side of the table. Okay, we as teachers, I think the students should be able to understand how it is to be on the other side. And I think you've done beautiful justice to the given topic. And I think it's one of the most difficult topics in neuro-ophthalmology, the visual pathway. And I specifically chose Hari to deliver this topic, and because I was confident in his abilities. And you've done real justice to your topic. An excellent presentation. I think that's the take-home message. Like, you should be able to attract your audience by giving them a lot of animations and making it as very simple as possible so that they can understand the whole concept. And you've done real good effort in it. A lot of effort into preparation of the slides, and I really appreciate your effort and being very sincere. Hari, excellent work, Hari. Excellent. I'm really proud of you. Excellent work. Good
Thank
job.
you, sir. Thank you very much, sir. It means a lot.
Yeah.
Sir.
Next speaker will be Anaga. Yeah.
Yeah, yes, sir.
Anaga, yeah, okay. So again, I've gone to the real extent of choosing people for each topic. So I was really confident of you guys. I knew that you will really do a lot of justice in this topic. And Anaga, all the very best. And I think you need no introduction for your own batch students. Maybe others will really know about you. You're at home, isn't it?
Yes, sir.
Hello, hello. Are you able to hear me?
Yes, sir.
Hello.
Yes, sir. I'm able to hear you.
Yeah, okay. You can start presenting, Anaga. Start
Yeah.
presenting.
Respected Dr. Parthiban, sir, all the faculty members, and my dear friends, good morning, one and all. I am Anakha Nair, pre-final year batch. The topic allotted to me is pupillary pathway and pupil abnormalities. Sarvasya gatrasya shiraha pradhanam, sarvendriyanam nayanam pradhanam, which means head is the most important part of our body, in that eyes are the most important sense organ. Pupillary reflexes. The pupil is under involuntary control. There are various ways in which pupil can reflexly constrict and reflexly dilate. Light reflex, near reflex, ciliospinal reflex. Ipsilateral pupil dilates due to pain on the neck, face, or the upper trunk. This reflex is absent in the Horner syndrome. Psychosensory reflex, dilatation of the pupil in response to stress. Light reflex. When a beam of light is shown on the eye, reflex constriction of both the pupil occurs. Two components, direct light reflex and indirect or consensual light reflex. Now, let us see a video regarding it. When a light is shown into one eye, the pupil of both the eyes normally constrict. Constriction of the pupil upon which the light is shown is called direct light reflex, while constriction of the pupil on the opposite side, even though no light fell upon that eye, is called consensual light reflex or indirect light reflex. The pathway of light reflex includes afferent fibers, which extend from the retina to the pretectal nucleus in the midbrain at the level of the superior corticula. The interstitial neurons connect each pretectal nuclei to both Edinger-Westphal nuclei. The preganglionic fibers connect the Edinger-Westphal nucleus to the ciliary ganglion. The postganglionic fibers leave the ciliary ganglion, passes in the short ciliary nerve to innervate the sphincter pupillae. Let us see a video clipping regarding it. When a light is shown into an eye, the fibers from each pretectal nucleus project to both Edinger-Westphal nuclei. From these, the fibers travel via the oculomotor nerve to the ciliary ganglion. The postganglionic fibers give supply to the circular muscle of the iris to cause constriction in the eye, which was exposed to light, called direct light response, as well as which was not exposed to light, called consensual response. Near reflex. When the gaze shifts from the far object to near object, three changes occur in our eye. Firstly, the convexity of the lens increases, and there is constriction of the pupil, known as miosis, and there is medial rotation of the eyeball. Near reflex is in fact a combination of two reflexes, converging reflex and accommodation reflex. Convergent reflex is a contraction of the pupil on convergence, and accommodation reflex is a contraction of the pupil on accommodation. Now let's see the pathways. The afferent from the medial recti travel via the third nerve, that is oculomotor, to the mesencephalic nucleus of the trigeminal nerve, to the presumptive convergent center in the pretectal region. From this, the impulse is relayed to Edinger-Westphal nuclei, and the subsequent efferent pathway of the near reflex is along the third nerve, that is oculomotor. The efferent fibers relaying the accessory ganglion before reaching the sphincter pupillae, resulting in constriction of the pupil. The pathway of the accommodation reflex initially follows the visual pathway. Impulses are carried by the afferent fibers from the retina to the striate cortex. These are then relayed to the parastriate cortex. From the parastriate cortex, impulses are relayed to Edinger-Westphal nuclei of both sides via the occipito-mesencephalic and pontine center. From the Edinger-Westphal nuclei, the efferent impulse travels along the third nerve, reaches the sphincter pupillae and ciliary muscle after relaying in the accessory ganglion and ciliary ganglion, resulting in constriction of the pupil. Next is the pupillary abnormalities. The first is the afferent pathway defect, APD. The first afferent pathway defect we will discuss is absolute afferent pathway defect, AAPD, or total afferent pathway defect, GAPD, or amaurotic pupil. The cause of this lesion is complete optic nerve lesion. Now, let us discuss case. Let us assume that lesion is in the right optic nerve. So when light is shown on the left side, that is the normal side, both the pupil will constrict, that is the lesion is in the right optic nerve, and both the pupil will constrict and both are of equal size, known as isocoria. When light is shown on the lesion side, that is a right optic nerve, there is lesion in the right optic nerve. So both the pupil do not react or constrict, they remain mid-dilated, known as isocoria. The second afferent pathway defect is related afferent pathway defect, RAPD, or Marcus-Gunn pupil. The cause of this lesion is partial optic nerve lesion and severe retinal diseases. Let us discuss a case. Let us assume that there is partial lesion in the right optic nerve. So when light is shown on the left side, that is a normal side, both the pupil will constrict because there is partial lesion only in the right optic nerve and of the same size, known as isocoria. When light is shown on the right side, initially there is constriction of pupil on the right side. Then light is shown on the left side, there is constriction of the pupil because the left eye is normal. And keep doing this. Then both the pupils seem to dilate when light is shown on the lesion side, that is a right eye in this case. This phenomena is known as paradoxical dilatation or pupillary escape phenomenon. Let us see a video regarding it. Here, the partial lesion is in the left optic nerve. The first light is shown on the right eye, there is constriction of the pupil. Then it is shown on the left side, there is constriction of pupil because there is only partial lesion in the left optic nerve. And keep doing it. When light is shown on the right eye, still it constricts. Because there is partial lesion in the left optic nerve, it gets fatigue earlier. So finally, when light is shown on the left eye, the pupil starts to dilate. Both the pupil will dilate. The third afferent pathway defect is Wernicke's hemianopic pupil. Here, the site of lesion is in the optic tract. The pupil doesn't constrict if the light is thrown in any eye from the side of visual loss. but both the pupils are constricted if the light is shown in any eye from the side where vision is present. Next is the efferent pathway defect. The first efferent pathway defect we will discuss is Argyll-Robertson pupil, popularly known as ARP. The cause of this defect is neurosyphilis most commonly, which is a tertiary stage of syphilis. The other causes are tabes dorsalis and aortic regurgitation. The site of lesion is in the rostral midbrain in the aqueductal gray matter. Let us see a video regarding it. If I throw light on the right, the pupil doesn't react. Again, I throw light on the left, the pupil doesn't react. There's a light reflex is absent, near reflex is present. Because the supranuclear inhibitory fibers are damaged, the Edinger-Westphal nucleus keeps on releasing the parasympathetic impulse to the sphincter pupillae. So the pupil is always seen to be constricted, that is miosis. The pupil remains constricted, that is, the pupil don't dilate in the dark. In Horner syndrome, even though the miosis is seen due to the dilated pupillae palsy, it shows a phenomenon known as dilatation lag. That is, in dilatation lag in darkness, for the first 5 seconds, the Horner's pupil doesn't dilate. For the 5 to 15 seconds, it starts to dilate. By around 5 minutes, it achieves complete dilatation. The next efferent pathway defect is tonic pupil or Adie's pupil. The site of lesion is the ciliary ganglion. The causes are orbital trauma, herpes-zoster virus ganglionitis, diabetics, alcoholism, and Holmes AD pupil. Let us discuss a case. That is, there is lesion in the right ciliary ganglion. So when light is shown on the left side, that is a normal side, the right pupil doesn't constrict, but the left pupil will constrict because there is lesion only in the right ciliary ganglion. That is, the right ipsilateral pupil doesn't constrict, ipsilateral consensual light reflex absent, but left contralateral pupil constricts. When light is shown on the right eye, that is on the lesion side, the right pupil will not constrict, but the left pupil will constrict. That is, a right ipsilateral pupil doesn't constrict, ipsilateral direct light reflex is absent. But near reflex is present, shows dilating vermiform movements. The third efferent pathway defect is pharmacological mydriasis. There is a use of atropine causes the pupil to get dilated and doesn't constrict the pupil to light. The pharmacological mydriasis, both light reflex and near reflex is absent. In tonic pupil, light reflex is absent, but near reflex is present. This flow chart is about anisocoria. Anisocoria means difference in size of the pupil that has to be greater than or equal to 0.4 mm. There are two conditions, that is anisocoria greater in dark and anisocoria greater in light. Let us talk about anisocoria greater in light. In light condition, normally both the pupil must constrict, but in anisocoria, one of the pupil must not constrict. That is, the abnormal pupil is dilated. So, if the shape is normal, if the shape is abnormal, there has to be some iris damage. But what if the shape is normal? Then we have to do a test to diagnose, that is with pilocarpine test. Normally, the pupil will constrict with 1% pilocarpine. So here we are using dilute pilocarpine, that is 0.1%. So we expect that the pupil should not constrict. But if the pupil constricts, there must be some abnormality, that is Adie's pupil due to deinnervation hypersensitivity. But if the pupil doesn't constrict, we will do 1% pilocarpine test. If the pupil constricts, the cause is third cranial nerve palsy, and the pupil doesn't constrict, pharmacological anisocoria. Anisocoria greater in dark on giving apraclonidine. If the abnormal pupil dilates, the diagnosis is Horner syndrome. If the pupil doesn't dilate, it is physiological anisopia. Let me express my sincere thanks to Dr. Parthiban sir and Niriyamuri ma'am for giving me an opportunity to present this and guided me in this whole venture. Thank you all.
Anaha, are you able to hear me?
Yes, sir.
Hello, can you hear me? Yeah, okay. Oh, you really amazed me, man. I don't know. Seriously, a beautiful presentation. I don't know. I haven't seen anyone present a pupil abnormality this beautifully. And especially your chart on that anisocoria, I just loved it. Okay. This is an excellent presentation. I don't know. I don't know how people can, you've been really awesome in all going to all the details regarding the innovations of pupil and the near reflex and the pathway for the near reflex. I think beautifully explained by you. I don't know, even my assistants, I don't know, they may find it difficult to this thing really understand. But you've been really very informative in your presentation. It's you've done very good effort into presenting on the pupil. It really amazes me how talented students are these days to really convey the message. Excellent presentation. Congratulations, Anaga. You've done a beautiful job. I'm so proud.
Thank you so much.
Okay, very good. Next, I would like to call upon Tarni. Tarni.
Yes, sir.
Okay, Tarni. Okay. As I was referring to earlier, like you've been chosen for this particular topic. So optic neuritis again is a very important topic for the undergraduates, and it is a definite university question. Optic neuritis, visual pathway, and these things, and visual pathway and a clinical app again could be a university question. Pupillary abnormalities, they may ask on one of the pupillary abnormalities, but just Anaga. So optic neuritis is definitely university question. You have to really understand the concept, and it may be asked as an essay question also. So all the best, very best, Tarni. Do your best.
Thank you so much, sir. Thank you, sir.
You can start, Ma.
Yes, sir. A very pleasant good morning to everyone. I would like to begin my presentation by thanking our most respected and esquired HOD sir, our beloved professors, and our kind and talented PGs of ophthalmology department for being our pillars of strength and making sure that we excel both in our academics and extracurriculars. So I think the knowledge provided by my previous presenters will help you to understand this topic too. I'm going to be presenting optic neuritis today. This is one of the most important pathological conditions affecting the optic nerve. So at the outset, let us see what is meant by the term optic neuritis. We all know that itis means inflammation. So optic neuritis means inflammation of the optic nerve. And this inflammation of optic nerve can occur in any part of its course. We'll be seeing about epidemiology, classification, pathology and etiology, clinical features of optic neuritis, the clinical workup that has to be done, differential diagnosis and treatment. So coming to epidemiology, around 1 in 1 lakh people become affected by optic neuritis. There's an increased female predominance with female to male ratio being about 5:1. It's more common in white people and it's more common in younger age group. So before going into detail about the topic, it is important for us to understand the basics of the structure involved in this condition, that is optic nerve. So optic nerve is composed of retinal ganglion cell axons and glial cells. The 8th and 9th layer of retina, that are the retinal ganglionic cells, and the neuronal layer consisting of axons of those ganglionic cells. So the axons present inside the retina are unmyelinated and they traverse the entire course of retina. They leave this eyeball through optic nerve head, and once they leave the eyeball, they acquire myelin sheath and travel as optic nerve. So the course of the optic nerve will include starting from optic nerve head to that of optic chiasma, and thereafter it continues as optic tract. So in this picture, you can appreciate the course of optic nerve. It starts from the optic nerve head all the way to the optic chiasma. You can also see the different parts of optic nerve. We have an intra-orbital portion inside the orbit, an intracanalicular portion inside the optic canal, and then we have an intracranial portion all the way to the optic chiasma. So you can also divide the optic nerve based on whether it is ophthalmoscopically visible or not visible. So the portion of the optic nerve ophthalmoscopically visible include the optic nerve head and the retinal ganglionic cell axons. So when an optic nerve head alone is affected by optic neuritis, we call it papillitis. When both the optic nerve head or as well as the retinal ganglionic cell axons are affected by optic neuritis, we call it neuroretinitis. And when the part of the optic nerve that is ophthalmoscopically not visible gets affected, that is the portion that is present behind the eyeball, we call it retrobulbar neuritis. So in the former, since the structure is ophthalmoscopically visible, there will be obvious signs. But in the latter, since it's not ophthalmoscopically visible, there will be no obvious signs, and the diagnosis has to be made based on symptoms and other tests. So papillitis occur frequently in children and young adults. Neuroretinitis is not so common, and retrobulbar neuritis is the most frequent type that occurs in adults. So coming to the pathology of optic neuritis, certain condition that involves the recruitment of inflammatory cells like inflammation or immune mediated disorders leads to perivascular infiltration of inflammatory cells. And these inflammatory cells feeds on the myelin sheath, leading to damage or destruction of myelin. And these disintegrated myelin are then removed by phagocytic cells. So this leads to proliferative gliosis and continuous damage to myelin and optic nerve. So coming to etiology of optic neuritis, it could be due to a primary demyelinating disorders or other condition that leads to demyelination. It could also be due to certain conditions that only cause inflammation and not demyelination. In cases where there are only inflammation and there is continuous recurrence, we call it chronic relapsing inflammatory optic neuritis. So you have to understand that optic neuritis basically means inflammation and not necessarily demyelination, although the latter is one of the most predominant feature of optic neuritis. So demyelinating disorders include multiple sclerosis, neuromyelitis optica, and Schilder's disease. When it's associated with infections, it could be due to endophthalmitis, orbital cellulitis, sinusitis, or contagious spread from meninges or bed, or it could be due to systemic infections. Coming to immune mediated disorders, it could be due to uveitis, sympathetic ophthalmitis, sarcoidosis, vegano-granulomatosis, acute disseminated encephalomyelitis. Even metabolic disorders like diabetes and anemia could be associated with optic neuritis. So most common causes of optic neuritis include idiopathic optic neuritis. The cause is not usually diagnosed, and multiple sclerosis is one of the most important cause of optic neuritis. Apart from this, it could be due to neuromyelitis optica, viral infections, post-viral or post-vaccination, infections like mycoplasma, mononucleosis, or contagious inflammation. So we saw that multiple sclerosis is the most important cause of optic neuritis. Around 50% of patients with multiple sclerosis become affected by optic neuritis. So here is an important concept that you have to understand. We saw that the portion of the optic nerve that is behind the eyeball is not ophthalmoscopically visible. And when this portion gets affected by optic neuritis, we call it retrobulbar neuritis. And again, in multiple sclerosis, it leads to demyelination. So if you correlate these 2 points, you'll understand that the type of optic neuritis associated with multiple sclerosis is most commonly retrobulbar neuritis. So when you diagnose a retrobulbar neuritis or multiple sclerosis, it's always important to suspect the other condition. So in this, you can see a normal optic nerve with a healthy myelin sheath. And here there is an inflamed optic nerve with a damaged myelin sheath. So inflammation of optic nerve and demyelination goes hand in hand to some extent. So coming to symptoms of optic neuritis, there is visual loss, sudden unilateral painless loss of vision, although there is orbital retroocular and brow pain. And this pain may precede visual loss, and it's increased or aggravated on eye movements. There can be neuralgia and headache along with tenderness of the eyeball. There can be loss of color vision, especially red and green color deficiency, along with loss of color contrast sensitivity. And there could be reduced perception of light intensity, and neurological symptoms like paresthesia could be present when there is an associated vitamin B12 deficiency. So there are two other important phenomenon. Pulfrich phenomenon, where there is altered perception to moving objects, and the Utov sign, where the patient experience worsening of symptoms with exercise or increase in body temperature, or even when they're exposed to heat. Coming to signs of optic neuritis, it includes decreased visual acuity, decreased color vision, abnormal contrast sensitivity, decreased stereo acuity, and two most important signs include visual field defect and abnormal pupillary reactions. Coming to visual field defects, the perimetry shows visual function depression over the entire field, but it is more marked in the central 20-degree. And the visual field could be central scotoma, centrocecal scotoma, or altitudinal defects, which occurs most commonly. Also, it could be enlarged blind spot or paracentral scotoma, nasal step, or quadrant scotomas. Coming to pupillary reactions, it is very important because it is one of the most important diagnostic feature. So, patient affected with optic neuritis has most commonly relative afferent pupillary defect. So, it is observed during swinging flashlight test. When the patient's pupil dilate when a bright light is swung from the unaffected eye to the affected eye. So, we call it Marcus gun pupil. So, in this video, you can see that when the patient eyes are healthy, there is both indirect and direct light reflex. But when the patient is affected with relative afferent pupillary defect, especially left afferent pupillary defect, when the light is shown on the left side, there is dilation instead of constriction of the pupils. But the unaffected eye, when the light is shown on the unaffected eye, there is both direct and indirect light reflex. So basically, when there is relative afferent pupillary defect and light is shown on the affected eye, there is dilation of the pupils instead of constriction of pupils. Coming to visually evoked potential, it is a highly advanced vision test, and it measures how well the entire vision system works, especially the impulse transmission. So, when a patient is affected by optic neuritis, their visually evoked potential shows prolonged latency, that is delayed transmission time and reduced amplitude. So, as you can see in this video, when the patient is healthy and the optic nerve is surrounded by myelin sheath, the impulse transmission is fast. But when the patient has optic neuritis and there is damage of myelin sheath, then the impulse transmission is impeded and it becomes a lot slower. So that is the prime importance of myelin sheath, right? It makes sure that the impulse transmission is fast and there is no loss of impulse energy. So coming to ophthalmoscopic picture, it is very important because it helps us to differentiate between papillitis, neuroretinitis, and retrobulbar neuritis. Coming to papillitis, the disc is hyperemic, margins becomes blurred, and there is swelling and edema. There is also peripapillary flame-shaped hemorrhages. And in the later stages, the retinal vein becomes tortuous and distorted. Also, you can see fine vitreous opacities. Coming to the fundus picture of neuroretinitis, it has the same features of papillitis except that there is additional retinal exudates in the nerve fiber layer, and these becomes radially oriented around the macula to form macular fan or star. Coming to retrobulbar neuritis, since the optic nerve that is not ophthalmoscopically visible becomes affected, the optic disc appears normal. You can call it as a condition where patient sees nothing and doctor sees nothing. Like the patient can have sudden loss of vision, but the doctor cannot see anything in the fundus examination. Also, rapid deterioration of vision along with the presence of normal fundus may also suggest hysteria. So it is a differential diagnosis of retrobulbar neuritis. Coming to the clinical course of optic neuritis. So in the second or third week, the vision starts to improve. In the fourth or fifth week, visual acuity returns to near normal. In the next month, vision slowly improves and it may even get restored to 6 by 6 vision. So this is very important because it is a feature that helps in differentiating optic neuritis from other conditions that the vision starts improving in the second week. In the 6 to 12 months, the color vision, contrast sensitivity, and visual field defects improve. It may take longer to recover than that of visual acuity and may never return to normal. In a small percentage of cases, the vision does not improve to functional levels or it does not improve at all. And this is what we call an atypical neuritis. So, in atypical neuritis, the patient is usually out of typical age range. There is no pain on eye movements, and there's a poor vision persisting beyond 2 weeks from onset. There's progressive diminution of vision beyond the first week. Coming to differential diagnosis of optic neuritis, the three most important differential diagnoses of optic neuritis include type 4 hypertensive retinopathy, diabetic papillitis, and anterior and posterior ischemic optic neuropathy. So, when coming to type 4 hypertensive retinopathy, it has similar clinical fundus picture similar to that of optic neuritis, except that it has cotton wool spots. So, optic neuritis has a very similar fundus picture to that of ischemic optic neuropathy too. And one differentiating factor is that ischemic optic neuropathy occurs in elderly age group, whereas optic neuritis affects a younger age group. So, one should hesitate to make a diagnosis of optic neuritis in a patient above 50 years, and we should suspect the presence of ischemic optic neuropathy. So, papilledema has a very similar fundus picture to that of early papillitis, and an important differentiating feature is that papillitis has Marcus gun pupil. And also in papilledema, the central vision is usually not affected. Apart from this, anterior ischemic optic neuropathy mimics papillitis, and posterior ischemic optic neuropathy mimics retrobulbar neuritis. Coming to other differential diagnoses, it includes Leber hereditary retinopathy, toxic and metabolic optic neuropathy, compressive space occupying lesion in the orbit or intracranially in the chiasmal region. So, coming to clinical workup, it is important to take careful history, age of the patient, rapidity of onset, occurrence of any previous episodes, or presence of pain on eye movements should be asked and noted carefully. The ophthalmic examinations that has to be done include visual acuity and color vision, assessing pupillary reactions, retinal examination with dilation of pupil, evaluation of the eye for vitreous, evaluation of the vitreous for cells, and also visual fields and the visually evoked potential should be tested for both eyes. And one of the important aim of clinical workup is to differentiate the types of optic neuritis. So when there are predominant symptoms, it helps us to differentiate optic neuritis from other differential diagnoses that can be made. And when you see the fundus picture, when there is presence of predominant signs, then it means that it's not retrobulbar neuritis. In retrobulbar neuritis, there is no predominant signs that can be seen. When you see predominant signs, then it must be papillitis or neuroretinitis, which could be further differentiated based on the presence or absence of macula star. And these additional tests have to be done in case of atypical optic neuritis, like complete blood count, estimation of rapid plasma reagent, and C-reactive protein, and anti-nuclear antibody test, and most importantly, magnetic resonance imaging. So MRI is very important and it helps us to decide the treatment for optic neuritis. So when a patient comes with, when we diagnose a patient with optic neuritis and we take baseline MRI, when there is demyelinating lesions, we refer to a neurologist and discuss the therapy. When there is no demyelinating lesions, we do regular follow-up. And when the vision does not improve even after 2 weeks and there is recurrent attack of optic neuritis leading to demyelinating lesions on MRI and appearance of neurological symptoms, again then we refer to a neurologist. So in this picture, you can appreciate the presence of right side optic neuritis. You can see the inflammation of optic nerve, and in comparison, you can see a healthy optic nerve on the left side. So this is the case of multiple sclerosis in a patient with right side optic neuritis. Even here, you can appreciate the inflammation of optic nerve on the right side, and you can see the lesions that are caused by multiple sclerosis. This is again a case of multiple sclerosis in a patient with right side optic neuritis. This is a coronal section, and here you can beautifully appreciate the presence of inflammation of optic nerve on the right side, and comparatively there is healthy optic nerve on the left side. And in this image, you can see there are hypertensive demyelinating plaques that are present in the supratentorial region, especially in the corpus callosum. It is very evident. So coming to treatment, which is very important, it is important for us to find the primary disease and provide appropriate treatment for the primary disease. And the optic nerve treatment trial guideline states that we should give treatment with IV methylprednisolone 1 gram daily for 3 days and oral prednisolone 1 milligram per kg per day for 11 days. So the dosage is very important. IV methylprednisolone 1 gram daily for 3 days and oral prednisolone 1 milligram per kg per day for 11 days. And this is given if there is profound visual loss. There is no previous history of multiple sclerosis, but still there is MRI showing at least one area of demyelination, and the dose has to be altered after 11 days. The dose has to be tapered after 11 days. And this treatment fastens recovery of visual acuity, reduces frequency of relapse, but does not necessarily affect the final visual outcome. And a CHAMP study states that it advocates use of beta interferon in patients after steroid regime, and this is to reduce subsequent risk of multiple sclerosis in patients of optic neuritis. So, use of only steroid in optic neuritis is contraindicated, but CRION responds highly to steroid. That is chronic recurrent inflammatory optic neuritis. And glatiramer acetate could be given 20 milligrams subcutaneously daily. So thank you. Hope this session was useful for you to understand the basics and concept of optic neuritis. And I would once again like to thank the Department of Ophthalmology and our HOD sir for providing this wonderful opportunity. I also thank everybody who's worked hard to make this webinar a successful event. Thank you. Now we'll see the two poll questions. So both of these are NEET PG questions. So which of the following statements regarding optic neuritis is false? You can read the options. Oral steroid therapy alone is contraindicated. MRI brain and orbit helps to decide the treatment. Steroids may help to decrease the duration of vision loss but do not affect the final visual outcome, and color vision recovers faster than visual acuity. So thank you. The option is color vision recovers faster than visual acuity. That is false because color vision takes a lot longer to recover, and but visual acuity improves just after 2 weeks. And second question, multiple sclerosis is commonly associated with which type of optic neuritis? Papillitis, retrobulbar neuritis, or neuroretinitis, or all of the above? Thank you for the response. The answer is retrobulbar neuritis. We saw that both retrobulbar neuritis and multiple sclerosis associated with demyelination, and myelin sheaths are present in the part of the optic nerve behind the eyeball. Thank you.
Unmute ஆயிடுச்சுங்க சார் இதுல. Harshana? Harshana, you continue. Sir is having some network issues.
Okay, all right, all right. A very good morning to one and all present here. I am Harshana Madhu, and today my topic is papilledema. Papilledema is an ophthalmic emergency. Generally, the patient is referred by another physician to the ophthalmologist, or it is detected accidentally during routine clinical checkup. So before we go into what papilledema actually is, let's look into a brief history about papilledema. This is Albert von Grafe. He, in 1860, found in 4 patients having brain tumor that there was swelling of the optic nerve head, and he termed it the choke disc. And later, in 1908, John Herbert Parsons coined the term papilledema. Coming to the contents, today I'll be discussing papilledema under the following contents: the definition, the causes, the pathogenesis, the symptoms and signs, the staging, the diagnosis, the differential diagnosis, and the treatment of papilledema. So first of all, what is the definition of papilledema? Papilledema is defined as a passive, non-inflammatory edema of the optic nerve head due to raised intracranial pressure, which is almost always bilateral and without visual deficit. If we break down the word papilledema into papillae, which means optic disc, and edema, which means swelling, papilledema is basically secondary because it is always secondary to the raised intracranial pressure. Therefore, it is passive. And it is without any visual deficit because papilledema, that is the optic disc, is nothing but the blind spot. Therefore, there can be no further loss of vision. But blindness can occur in cases of untreated papilledema or long-standing chronic papilledema. Next, moving on to the causes of papilledema, intracranial space-occupying lesions like tumors, aneurysms, abscess form an important cause of increased intracranial pressure, and hence they can lead to papilledema, out of which tumors are the most common cause. Next, intracranial infections like meningitis and encephalitis can also cause papilledema. Trauma leading to subarachnoid hemorrhage can cause papilledema. Pseudotumor cerebri, which is also known as idiopathic or benign intracranial hypertension, which is most commonly seen in young obese females, can also lead to papilledema. Obstructive hydrocephalus and other systemic conditions like malignant hypertension and toxemia of pregnancy can also lead to papilledema. As I mentioned before, papilledema is most often bilateral. There are few causes which are unilateral, out of which Foster-Kennedy syndrome causes unilateral papilledema. Here, there is frontal lobe glioma or sphenoidal or olfactory lobe meningioma, which leads to pressure optic atrophy on the same side of the mass and contralateral papilledema due to the generalized raised intracranial pressure. Next, pseudo-Foster-Kennedy syndrome also causes unilateral papilledema. Here, the cause is anything other than a mass. There is ipsilateral papilledema and a pre-existing contralateral optic atrophy. Next, moving on to the pathogenesis of papilledema, throughout the years, various theories were put forward to explain the theory about papilledema. Few of the olden theories were classified into mechanical theories and non-mechanical theories. So the Gover's theory of inflammation tried to explain papilledema on a toxicological basis. That is, it stated that the toxins that are elaborated into the CSF was the reason for papilledema. Next, Jackson's theory of vasomotor instability. This stated that the nerves and the vessels that are supplying the optic nerve head had some damage, and that was the reason for papilledema. And other non-mechanical theories were venous obstruction at the optic disc, obstruction to the normal flow of tissue fluid along the optic nerve, and in general edematous conditions of the brain, forcing of CSF into the optic nerve head caused papilledema. But none of these theories were proved, and hence right now the most commonly accepted theory for papilledema is the hair race theory. So before I talk about what hair race theory actually is, let's look into a few basic concepts. So in this picture, this structure is the lamina cribrosa, which is a sieve-like structure, and it separates the optic nerve into the intraocular part and the retroocular part. The pressure in this part is generally higher than the pressure in this part. That is, the intraocular pressure is higher than the intracranial pressure. And this is the normal pressure gradient across the lamina and tuberosa, and this facilitates the normal flow of axoplasm along the axons. But if there is any problem in this pressure gradient, that is, if the intracranial pressure rises or the intraocular pressure falls, there will be no flow of axoplasm, and hence there will be axoplasmic stasis. So what is this axoplasmic transport that we continuously keep talking about? The axoplasm normally continuously flows along the axons. It consists of mucopolysaccharides, glycolipids, phospholipids, and other associated elements. There are two types of axoplasmic transport, the anterograde transport and the retrograde transport. The anterograde transport is from the retinal ganglion cells to the lateral geniculate body, and the retrograde transport is from the lateral geniculate body to the retinal ganglion cells. So as I mentioned, there is flow of axoplasm from the retinal ganglion cell to the lateral geniculate body, which is situated at the level of the superior colliculus. So this is the picture showing the normal optic disc where the CSF pressure is also normal. So here, coming to the Hayes theory states that when there is increased intracranial pressure, it gets transmitted along the subarachnoid space to the region of optic nerve, because the meninges covering the optic nerve and the brain are the same, and that leads to axonal transport block, causing axoplasmic stasis and swollen optic disc. So this is a picture showing normal CSF flow. The production of CSF starts in the lateral ventricle and it moves into the third ventricle. From there, through the aqueduct of Sylvius, it goes into the fourth ventricle, and from there it goes to the central canal of spinal cord and to the subarachnoid space. So if there is any problem in this flow of CSF, it can lead to obstructive hydrocephalus, raised intracranial pressure that gets transmitted to the optic nerve and leads to axoplasmic stasis. So this video shows the flow of normal CSF. This is the optic nerve where the CSF pressure is normal. There is normal blood supply to the retina and the optic nerve. And if there is increased CSF pressure, so here we see that the CSF pressure is increased. Therefore, the blood supply to the eye and the retina has been compromised. And further, there is compressed optic nerve, which leads to irreversible optic nerve damage. If we look into the fundus picture, we see that there is bulging of optic disc and the vessels have been obscured, which is a sure sign of papilledema. Next, coming to the symptoms of papilledema, most of the symptoms of papilledema is due to the raised intracranial pressure, out of which headache is the first and most common symptom of papilledema. Along with that, there can be nausea and vomiting, transient blurring or loss of vision, which is also known as amaurosis fugax, and diplopia. So why is that diplopia in papilledema? Diplopia is caused due to sixth nerve or abducens nerve paralysis. So in this picture, we see that the sixth nerve is curving around the sharp petrous tip. Therefore, when there is increased intracranial pressure, the pressure gets applied here, and therefore there is sixth nerve paralysis leading to diplopia. Next, coming to the signs of papilledema, the signs are classified into mechanical signs, which is explained by the extracellular edema that is caused due to the axoplasmic stasis, and vascular signs, which is due to secondary venous congestion. So the first mechanical sign is blurring of the disc margin. This is the earliest sign of papilledema. It starts in the nasal side and slowly progresses to the superior, inferior, and temporal side. Then the disc becomes edematous and elevated. There is edema in the retinal nerve fiber layer, and there are Paton's lines. These Paton's lines are nothing but just grayish circumferential folds in the retina due to the edema present in the retinal nerve fiber layer. Coming to the vascular signs, there is hyperemia of optic disc, venous engorgement and congestion, peripapillary splinter hemorrhages and cotton wool spots, which are superficial, and then there is macular star appearance. This is because the hard exudates radiate around the fovea in a star-like manner. Therefore, the term macular star appearance. Then there is absence of normal venous pulsations. But this cannot be a surest sign of papilledema, as it is absent even in 20% of the normal population. Next, moving on to the staging. According to the duration of papilledema, it is classified into early papilledema, established papilledema, chronic papilledema, and atrophic papilledema. So in established papilledema, the optic disc looks like that of a mushroom or dome-shaped appearance. Therefore, the vessels sharply bend around the corner. And in chronic papilledema, the optic disc looks like that of a champagne cork, And along with that, there are small drusen-like deposits, which is known as corpora amylacea in and around the region of the optic disc. 6 to 9 months from the onset of chronic papilledema, atrophic papilledema can occur due to the secondary optic atrophy, and that's when the blindness sets in. Currently, the most commonly used scale for grading papilledema is the Frisson scale of grading. So this is grade 0, where the optic disc is almost normal. There are no major changes seen. In grade 1, there is a C-shaped halo that is seen along the nasal margin, whereas the temporal side is normal. In grade 2, there is a circumferential halo where nasal, superior temporal, and the inferior margins are not clear. In grade 3, there are loss of major vessels while leaving the optic disc. In grade 4, there are loss of major vessels on the optic disc. And in grade 5, there is obscuration of vessels on and while leaving the optic disc. Next, moving on to the diagnosis, routine and proper history taking is the basic to diagnose any disorder. Along with that, proper physical examination and BP measurement should also be done, as malignant hypertension is a cause of papilledema. Pupillary and color vision assessment can also be done, as an abnormal pupillary and color vision almost rules out papilledema, as in papilledema, the pupillary reflex and the color vision is mostly normal. Next, moving on to the fundus examination. Here, as mentioned before, we see that there is blurring of the disc margin, there is obscuration of the blood vessels, there are cotton wool spots, the optic disc has been swollen, and there can be hemorrhages too. So the next diagnostic modality is the fundus fluorescence angiography. So in this, in early stages of papilledema, there is disc capillary dilation and light leakage of dye on the region of optic disc is seen. But as the papilledema progresses, that is towards the later stages of papilledema, the leakage of dye occurs on and beyond the optic disc. So the next diagnostic modality is ultrasonography. Ultrasonography is basically a very cheap, safe diagnostic modality. So first, we measure the optic nerve sheath diameter. So here, as we can see, the optic nerve sheath diameter has been increased, which signifies that there is increased intracranial pressure. Along with that, there is a slight bulging of the optic disc into the vitreous seen. This is because of optic disc swelling. The next one is the B-scan ultrasonography. So this white arrow points towards the normal hypoechoic area, which is the optic disc. And behind that, this hypoechoic area, it is known as crescent sign. It represents increased separation of nerve and its sheath. This sign is also known as the donut sign. And this test can be used to differentiate papilledema from pseudopapilledema. So the next one is the 30-degree test. Here, what we do is we measure the optic nerve sheath diameter in primary gaze, that is 0 degree, and at 30-degree gaze. So when there is more than 15% reduction in the optic nerve sheath diameter from primary gaze to the 30-degree gaze, that is a positive sign. This test can be used as a screening test for papilledema because this test is highly sensitive but not very specific. So the next diagnostic modality is CT. CT can be done if MRI is contraindicated in the patient, or MRI with gadolinium enhancement can also be done, and lumbar puncture can be done to diagnose increased intracranial pressure. But before doing lumbar puncture, we have to rule out any intracranial space occupying lesion, because if lumbar puncture is done in the presence of an intracranial space occupying lesion, there is a possibility of herniation of the brainstem contents towards the LP-induced low pressure area. So next, moving on to the differential diagnosis. Pseudopapilledema is a very major differential diagnosis that has to be differentiated from papilledema. The difference is that pseudopapilledema is not a true disc swelling. The vessels overlying the disc are not obscured. The disc is not hyperemic, and the buried drusen is identified with B-scan ultrasonography. Along with that, hypermetropic eyes is also a differential diagnosis, because in hypermetropia, we all know the axial length of the eyeball is shortened. So if it is shortened, the optic disc appears smaller, and when the vessels try to leave through the optic disc, it gets crowded around the optic disc margin, and that leads to blurring of the optic disc while seeing through ophthalmoscope. The other differential diagnoses are papillitis and ischemic optic neuropathy. Coming to the treatment of papilledema, Immediate hospitalization is a must because papilledema is an ophthalmic emergency. Treatment of underlying cause serves best for the patient in the long run. Cerebral decompression can also be done to decrease the intracranial pressure. If there is pseudotumor cerebri, lumboperitoneal shunting has to be done to drain the excess CSF into the peritoneal cavity. And along with that, optic nerve sheath decompression can also be done if there is decreased visual acuity. And weight loss should also be done as a treatment modality for patients with pseudotumor cerebri. So I would like to conclude by saying that the eyes are the window to the intracranial pressure. Therefore, looking into the eyes at the fundus at the right time will save the patient from serious consequences. Thank you. So I would like to show the poll.
Harshana, stop your screen sharing so that
Oh, yeah. Sorry. Okay. Okay. So this is the first question. Take about 10 seconds time. The earliest sign of papilledema is? Okay, I'll end the poll. Okay, that's right. Blurring of disc margin. The blurring starts from the nasal side and then progresses to the inferior, superior, and temporal side. Okay, next question. Okay. All statements are true about papilledema except. 5 seconds up. All right. Okay, that's great. Yeah. Disruption of neurofilament is the right answer. Okay. I'd like to thank one and all for listening to my lecture patiently. And I would like to specially thank our respected HOD sir for having given me this wonderful opportunity that I'll cherish forever, and the entire ophthalmology department. And special thanks to Dr. Vijay Bharati ma'am for guiding me throughout this. Thank you so much.
You able to hear me?
Yes, sir. Yes, sir.
Okay, good man. Very good presentation. Lovely. I know your diction, your talk is excellent. Of course, I was not able to log into my computer, but I'm doing it from my postgraduate's computer. So, very well done.
Thank you so much, sir. Thank you so much, sir.
Beautiful presentation, and I love the way that you spoke also. Very good. Congratulations,
Thank you,
Ashana.
sir.
Very good.
Thank you so much, sir. Thank you so much, sir.
And I love the way that you spoke also. Next one.
Mahalakshmi, sir.
Can you hear me? You start, Mahalakshmi. Good. Start.
Yes, sir. Good morning, everyone. My topic is oculomotor nerve palsy. We'll straight away go to the topic. The oculomotor nerve is a somatic motor nerve which supplies all the extraocular muscles except the lateral rectus and the superior oblique It supplies the intraocular muscles, which are the sphincter pupillae and the ciliary muscle. It also supplies the LPS. This is a picture showing all the muscles supplied by the oculomotor nerve. We'll see about the oculomotor nucleus, which is situated in the ventromedial part of the midbrain at the level of the superior colliculus. It is situated ventral to the sylvian aqueduct. It has two components, the main motor nucleus and the accessory motor nucleus. The main motor nucleus has various subnuclei. The first one is the levator subnucleus, which is an unpaired caudal midline structure. It innervates both the levator muscles. So a lesion to this levator subnucleus causes bilateral ptosis. This is a patient with bilateral ptosis. Next, we'll see about the superior rectus subnuclei, which is a paired nuclei. Each innervates the contralateral superior rectus muscle. So, a nuclear third nerve palsy spares the ipsilateral muscle and it affects the contralateral superior rectus muscle. The medial rectus, inferior rectus, and inferior oblique subnuclei are all paired structures. They innervate their corresponding ipsilateral muscles. So, the vascular diseases, primary tumors, and metastasis can affect these nuclei, and the lesion of these nuclei is often associated with adjacent fourth nerve nucleus palsy as well. This is a diagram of the oculomotor nuclear complex. As you can see, the levator palpebrae nucleus is an unpaired structure which supplies both the LPS muscles, and the superior rectus is a paired structure supplying contralateral superior rectus, and the inferior oblique inferior rectus and medial rectus supply the ipsilateral muscles. As you can see above, this is the Edinger-Westphal nucleus, which gives off pupilomotor fibers. We'll see about nuclear third nerve palsy. It causes we can see the right third nerve nucleus, which presents with complete ipsilateral right third nerve palsy and bilateral ptosis due to involvement of the LPS nucleus. We'll see about a condition called internuclear ophthalmoplegia, which is the inability to perform conjugate lateral gaze movement, and the patient presents with ophthalmoplegia. This is due to damage to the interneuron between the nuclei of cranial nerve 6 and 3. So this is termed as internuclear ophthalmoplegia. The interneuron which is getting damaged in this condition is the medial longitudinal fasciculus. We'll see about Webino, which is nothing but a wall-eyed bilateral internuclear ophthalmoplegia. As the name says, there is involvement of paired medial rectus subnuclei causing bilateral involvement. The most common etiology of this condition in older persons is infarction of the midbrain, and in young patients it is demyelinating disorders. So the patient presents to us with exotropia with defective convergence and adduction. Here you can see a case of Webino presenting with exotropia and defective convergence and adduction. Next is the accessory motor nucleus, which is nothing but the Edinger-Westphal nucleus. It has one median and two lateral components. The median component is known as the nucleus of Purlia. It gives off preganglionic parasympathetic fibers to the pupil. The cranial half is responsible for controlling the light reflex, while the caudal half is responsible for the accommodation reflex. We'll see about the course and distribution of the third nerve. It has four parts, the fascicular, basilar, intracavernous, and intraorbital. This is a picture showing the course of the third nerve arising from the third nerve nucleus. This is the fascicular part passing through the red nucleus, and this is the basilar part passing between the posterior cerebral and superior cerebellar arteries. Here it passes parallel to the posterior communicating artery and it enters the cavernous sinus. This is a radiographic image showing the same course of the third nerve. We'll see about the fascicular part of the third nerve. The efferent fibers arise from the third nerve nucleus. They pass along the red nucleus and the medial aspect of the cerebral peduncle. They reach the midbrain and then travel through the interpeduncular space. The causes of nuclear and fascicular lesions are often similar. However, demyelinating disorders may affect the fascicular part more than the nuclear part. Here, the picture shows a lesion of the fascicular part of third nerve causing complete ipsilateral third nerve palsy. Next is Benedict syndrome. These are all, we'll see about the various syndromes associated with fascicular third nerve palsy. First is the Benedict syndrome, when we have a lesion at the level of red nucleus. So there will be ipsilateral third nerve palsy and contralateral extrapyramidal signs such as hemitremor. So this is a picture showing a lesion at the level of red nucleus. This is a case of Benedict syndrome. Next, we have Weber syndrome, where the lesion is at the level of cerebral peduncle.
We have ipsilateral third nerve palsy and contralateral hemiparesis. This is a picture of Weber syndrome wherein you can see the lesion at the level of cerebral peduncle. Next is the North-Nagel syndrome, wherein the lesion is at the level of fasciculus and the superior cerebellar peduncle. Here there is ipsilateral third nerve palsy and there is cerebellar ataxia. This is a picture of North-Nagel syndrome, wherein you can see that the lesion is at the level of the fasciculus and superior cerebellar peduncle. Next is Claudy syndrome. It is nothing but the combination of Benedict and North-Nagel syndrome. As for Benedict syndrome, we have involvement of the red nucleus, and for North-Nagel syndrome, we have involvement of the superior cerebellar peduncle. This is a picture of the Claudy syndrome. Next, we'll see about the basilar part of the third nerve, which arises as a series of rootlets which leave the midbrain on the medial aspect of the cerebral peduncle. These rootlets coalesce to form the main trunk of the nerve, and the nerve passes between the posterior cerebral and the superior cerebellar arteries, and it runs parallel to the posterior communicating artery. And in the basilar course, it is unaccompanied by any other cranial nerve. So whenever we see a case of isolated third nerve palsy, we should suspect a basilar part palsy. So this is the picture showing the basilar course of the third nerve, where it passes parallel to the posterior communicating artery. So we'll see about the causes of basilar third nerve palsy. The first one is aneurysm of the posterior communicating artery at its junction with the internal carotid artery. This produces a pupil involving painful third nerve palsy. In this case, the extent of pupillary involvement often exceeds the severity of ophthalmoplegia or motility dysfunction. This is an aneurysm of the posterior communicating artery compressing over the third nerve. This is a radiographic image of the posterior communicating artery aneurysm. So next cause is head trauma. Head trauma can manifest as extradural hematoma or subdural hematoma. The hematoma causes tentorial pressure cone with downward herniation of the temporal lobe. So this herniation compresses the third nerve as it passes over the tentorial edge. So the patient presents with irritative meiosis followed by mydriasis, and gradually complete third nerve palsy is present. So this is a picture of an extradural hematoma which causes a tentorial pressure cone with herniation of the temporal lobe compressing over the third nerve. Next is the intracavernous part of the third nerve. The third nerve pierces the dura just lateral to the posterior clinoid process. It runs in the lateral wall of the sinus above the fourth nerve. So in the anterior part of the sinus, it divides into superior and inferior branches. Both the branches enter the orbit through the superior orbital fissure within the annulus of Sinn. So this shows the intracavernous part of the oculomotor nerve. Here is the oculomotor nerve. Below it is the fourth nerve, and then we have the sixth nerve here, and then we have the first division of trigeminal nerve here. So we'll see about the causes of intracavernous third nerve palsy. It can arise due to diabetes and aneurysm of internal carotid artery, due to pituitary apoplexy, which are pituitary tumors, then meningioma, carotid cavernous fistula, and granulomatous inflammations like Tolosa-Hunt syndrome. As I mentioned, due to the close relationship of the other nerves, there is involvement of fourth, sixth, and first division of trigeminal nerve along with the third nerve palsy. So this is a picture showing the superior orbital fissure, wherein we can see the superior division of oculomotor nerve and inferior division of oculomotor nerve passing through the annulus of Sinn. Next is the intraorbital part, which has two divisions, as I said earlier. The superior division innervates the levator muscle and the superior rectus muscle, and the inferior division innervates the medial rectus, the inferior rectus, and inferior oblique muscles. The branched inferior oblique also contains preganglionic parasympathetic fibers from the Edinger-Westphal subnucleus. This is a picture showing the superior branch innervating the LPS and the superior rectus, and the inferior branch supplying the medial rectus, inferior oblique, and inferior rectus. As you can see here, the inferior oblique also carries preganglionic parasympathetic fibers to the ciliary ganglion. So the superior and inferior divisional palsies are commonly traumatic or vascular causes. The lesion of superior division produces an upper eyelid ptosis, and there is limitation of supraduction or elevation, particularly with the eye in an abducted position. This is because the superior rectus, which is getting damaged here, is a supraductor in the abducted position. Next, in the lesion of inferior division, there is limited adduction and depression, and we have a dilated pupil. We'll see in short about the pupilomotor fibers. These are located superficially in the supraomedial part of the third nerve. Their main blood supply is from the pile blood vessels, while the main interior trunk of the third nerve is supplied by vasa nervosum. So here is the Edinger-Westphal nucleus. These are the preganglionic parasympathetic fibers reaching the ciliary ganglion. They relay in the ciliary ganglion, and these are the postganglionic parasympathetic fibers reaching the sphincter pupillae muscle. So the lesions of the pupillary fibers can be divided into medical and surgical lesions. The surgical lesions include aneurysm, trauma, and uncal herniation. These lesions characteristically involve the pupil because they compress from outside, so the pile blood vessels are damaged and the superficially located pupillary fibers are also damaged. Whereas in case of medical lesions, which are usually due to hypertension and diabetes, they spare the pupil because these are microangiopathies which involve the vasa nervosum. So this causes ischemia of the main trunk of the nerve, but the superficial pupillary fibers are often intact. The patient presents with marked periorbital pain and motility disturbance. This is a picture showing an aneurysm or a tumor which is compressing the pile blood vessels from outside, whereas this is a microangiopathy damaging the vasa nervosum. So this is a cut section of the same thing. In an aneurysm, we will have a pupillary dilatation, and in a medical lesion, we'll have pupillary sparing. We'll see about the signs of third nerve palsy. There is profound ptosis due to the weakness of LPS muscle. There is abduction and depression in the primary position. This is called as down and out position. This is due to the unopposed action of the intact lateral rectus and superior oblique muscles. There is intorsion of the eye due to the intact superior oblique, which increases on attempted down gaze. So the patient has normal abduction due to intact lateral rectus, limited adduction due to medial rectus weakness, limited elevation due to superior rectus and inferior oblique weakness, limited depression due to inferior rectus weakness. Whenever there is a parasympathetic palsy, there is a dilated pupil and defective accommodation. This is a video showing the unopposed action of lateral rectus and superior oblique muscle, which cause the eye to move in a down and out position. And due to the parasympathetic palsy, we'll be having pupillary dilatation. And further, due to the weakness of the levator palpebrae superioris, the patient will have a ptosis as well. So this is a patient with right third nerve palsy who has ptosis. On examination, he has normal abduction, but the adduction is limited, and the patient has limited supraadduction and limited infraadduction. We'll see about aberrant regeneration of third nerve following palsy. This can follow acute traumatic and compressive palsy because in these cases, the endoneural nerve sheath is often damaged. But these are not seen in vascular causes because the nerve sheath is intact. The pupil may also be involved in aberrant regeneration. We'll see about a sign called pseudography or pseudo-Von-Graphy phenomenon. These are nothing but bizarre defects in ocular motility. For example, there is elevation of upper lid on attempted adduction or depression. This is caused due to the misdirected regenerating axon, which reinnervate the incorrect extraocular muscle. So this is a patient with left third nerve palsy and apparent regeneration. Here, the patient is has reduced adduction on attempted right gaze, and he has lid elevation. And here you can see the limited depression, and the patient has lid elevation. So this is termed as pseudo-Von-Graphy sign. Next we'll see about causes of isolated third nerve palsy. These include microvascular disease, aneurysm, trauma, miscellaneous cause, and episodic causes. We have already seen about the microvascular disease and aneurysm. Coming to trauma, both direct trauma and secondary to subdural hematoma with uncal herniation can cause third nerve palsy. So whenever we have a case of third nerve palsy following relatively trivial head trauma, we should suspect an underlying aneurysm or tumor. This is an image of subdural hematoma, which is causing an uncal herniation. So coming to miscellaneous causes, we have tumors, we have giant cell arteritis, we have inflammatory disease like syphilis, Lyme's, and sarcoidosis, and vasculitis associated with collagen vascular disorders. Episodic third nerve palsy is nothing but we have brief episodes of third nerve palsy with spontaneous recovery. So this is often idiopathic, but there are certain etiologies like migraine, compression, and raised ICT. Myasthenia gravis mimics intermittent pupil sparing third nerve paralysis. Coming to investigations, we'll first do a cardiovascular assessment for the patient. A CT angiography is done whenever an aneurysm is suspected as an etiology because the patient presents with milder motility dysfunction and pupillary involvement. An MRI can also be done, MRI brain and orbits with venography and for specific exclusion of brainstem stroke or tumor and a cavernous sinus or orbital apex lesion. We can also do a conventional cerebral angiography. So this is the guideline for management of a patient with third nerve palsy. If it is a child less than 10 years of age, irrespective of the pupillary sparing or involvement, we have to do an MRI and MR angiography. And if it is normal, we have to proceed for cerebral angiography. In patients older than 3 years, we divide into pupillary involving and pupillary sparing. If there is pupil involvement, we go for an MRI and MR angiography, and we do a cerebral angiography. If it is a pupil sparing third nerve palsy, we do an MRI and MR angiography, and we do medical evaluation for diabetes and hypertension. We observe for the pupillary involvement, and we follow up the patient for further neurological abnormalities, if any. And patients above 50 years, if they have a pupil sparing third nerve palsy with total somatic involvement, we observe the patient and do the medical workup for diabetes, hypertension, and giant cell arteritis. While if the patient has partial pupillary involvement, which is defined by anisocoria more than 2 mm, but pupil not fixed and dilated. So this patient has to undergo an MRI and MR angiography. If they are normal, we have to do a cerebral angiography. Other supplementary investigation can be done for if an infection or a vasculitis is suspected as an etiology. We can do a lumbar puncture in required cases. Coming to treatment, observation, we have to observe the patient because in presumed microvascular cases, majority of the cases will resolve over weeks or months. So, and we have to concentrate on treating the main underlying cause of the palsy. Other modalities of treatment include temporary Fresnel stick-on prisms, especially if the angle of deviation is small. We can do an uniocular occlusion or patching to avoid diplopia if ptosis component is partial or recovering. We can give a botulinum toxin injection into the uninvolved lateral rectus to prevent its contraction when recovery time is prolonged. This is an image of the Fresnel stick-on prism. Coming to surgical management, the ocular motility element and ptosis can be corrected by surgical management, but the surgery is contemplated only after the spontaneous improvement has ceased. So the surgery is not taken up earlier than 6 to 12 months from onset of the palsy. These are my references. I would like to thank our Department of Ophthalmology for giving me this opportunity. I would also like to thank our HOD sir, Dr. Pathiban sir, and Dr. Helen ma'am, and all my professors and PGs for guiding me through this presentation. Thank you, everyone. And we'll now see the poll.
You able to hear me, Mahalakshmi? Kekida?
Yes, sir. Yes, sir, I'm able to hear you, sir.
Yeah, okay. Very good presentation, man. Very good.
Thank you, sir.
Are you able to hear me?
Yes, sir, I'm able to hear you, sir.
Yeah, very good. A lovely presentation. It's a very difficult topic. Third nerve palsy is mostly a postgraduate topic. You did excellently for undergraduate. Your presentation was really very good, up to a PG standard. I love the way that you presented all the levels of the lesions and highlighting both the medical and the surgical costs of third nerve palsy, the treatment wise and the investigation. Excellent presentation.
Thank you so much.
I did see Tarni's this thing also. I've reviewed. I was actually guiding her, so I've seen her slides before, and I know how well she presents. And I was actually watching her, hers and Archana's through the PG's phone, so no issues. So I've seen their presentations also. So the most they were also very good actually. Yeah. Finally, to sum it up, I chose neuro-ophthalmology because I know it's a very difficult topic. So it was just a teaser, and I just want to test how well the undergraduates are performing for this. So kudos, you guys have really lived up to my expectations. Neuro-ophthalmology is not an easy topic, And I wanted you people, basically this thing is to involve the students and let them also learn, because most of the time we really have a hatred towards neuro-ophthalmology. When we come into neuro-ophthalmology, people tell, ayo, bokeh and all that. Yeah, so actually I wanted the undergraduates to really understand the importance of neuro-ophthalmology and wanted you to evince an interest in the field of neuro-ophthalmology. So neuro, for an undergraduate level, you guys were excellent. You were really above the excellence. So excellent presentations. Anaga, Hari as usual is very good, and Tarni obviously have been slides were really very representative, very simple. The concept is nothing very flashy. I wanted people to have videos and animated slides, and it should be very minimalistic. There should not be extensive. There's nothing. And my simple this presenting is you're not supposed to make it very elaborate. Your slides should be very simple, and that's what I was. Slides have to be really very simplistic. A lot of diagrams and very informative. A lot of animation so that people can understand them beautifully. And you guys have really lived up to my expectations, and more than my expectations. You guys have done really exceedingly well. And I am proud of Spiloclasters. So excellent webinar, and really very contented. Thank you to all, and the best speaker. I think all you guys are very good. All you five have really been. I've selected you people from all the other contestants. It doesn't mean that you are the only five who are capable of talking. There are so many other people in the batch who are really capable of talking and presenting. But I gave you guys an opportunity to perform, and you performed exceedingly well. So இதுல 5 பேர்ல இருந்து யாரை choose பண்ணோம் for the best speaker அப்படின்னு சொன்னா it's very difficult for me. I think all five of you have been really very good. I don't want to single out anyone and give them individual this thing is saying that you were the best among the lot. And I don't know, maybe you guys can have a poll and let me know who was the best speaker amongst yourself. So maybe you can send me your feedbacks, okay, through oculofest. You people can tell me. And personally, I feel all of you were very good. Excellent. I want you guys to come on screen. Video, எல்லாருமே வாங்க. 5 presenters. Hari, Tarni, okay, Ashna, Anaga, all of you. Come on screen.
Yes,
Are you guys able to see me?
Yes, sir.
yes, sir. No, sir.
No, sir.
No, sir. No, sir.
Where are the others? Are they here? Tarni, you're not sharing a video.
So my video is on, sir.
Okay, I think I'm not able to see the others, but anyway, a real very good success, and I'm really proud of 2017 batch and doing an excellent presentation. wait for it. Lots of competitions, and I want every team to put in a lot of hard competitions. And this went on very well, successfully. Your symposium speakers, you've been exceedingly well. Thank you. We meet again. I actually was proposing the best speaker award, but I don't think I want to really single out anyone. So all you guys are my students. All of my children. So all of you guys are really very good and very talented. So it doesn't mean that there will be one's individual person who's been very best, the best about the lot. So all 5. So kudos to all 5. Thank you. I love you guys.
Thank you, sir.
Thank you,
Thank you,
sir.
sir.
All the best.
Thank you, sir.
Thank you, sir.
Thank you, sir. Thank you, sir.
Thank you. You can post your feedback. You can post your things. Feedback on this thing. People, other colleges people who participated. Yeah, you can post your feedback onto the on oculofest